So as I said, this topic is as new to me as it is for most of the people in the audience, except the fact that I have taken part in a clinical trial on semaglutide, oral semaglutide. So I'm going to talk in the next 10 minutes on oral GLP-1 receptor agonists. And whenever a new drug is introduced, we know that we expect the drug to produce good control of diabetes. We don't expect any gain. We don't expect any off-target effects, beyond glycemic control. We don't expect hypoglycemia either. And we expect the A1C to be between 6 and 7%. Now, if you take the GLP-1 receptor, GLP-1 hormone in the human body, it addresses 6 out of 8 octate mechanisms which we talk of. It acts on the liver, heart and blood vessels, brain, the pancreas, and in the kidneys, muscles. It acts in all the intestines. So it acts on all the other, the 6 out of 8 octate mechanisms. So it's a wonderful drug. And as somebody who has been using injectable GLP-1 receptor agonist, I quite welcome oral semaglutide. We know that injection has been a problem to patients because they don't like the word injection. And you can see that in this global internet survey of 1,250 physicians, they said that we don't like injections. The patients said they don't like injections. So if you see you have to use a vial or a pen to inject, even then it's painful. It is involving poking, and tablets are preferred any day by patients. So we have the Pioneer study about which I'm going to talk to you. Pioneer stands for Peptide Innovation in Early Diabetes Treatment. Peptide Innovation in Early Diabetes Treatment. And you can see the rationale for oral delivery of peptides. Usually we think that peptides cannot be delivered orally. So that is where the oral semaglutide is going to score over all the other molecules. So it improves the patient compliance. Patients accept treatment with oral drugs, any oral drugs at any point of time. We were talking about metformin in pre-diabetes. So why not oral semaglutide soon after metformin? And it also addresses all the barriers associated with injections. Now, what happens in the GI tract? I'm going straight away to the slide. When you give oral peptides, if you give insulin or GLP-1 hormone, it gets enzymatically degraded in the stomach because of the low pH and proteolytic enzymes which are present in the stomach. There is limited permeability across the gastrointestinal epithelium, and it has got a very low oral bioavailability. So these are 3 problems which we have with any peptide, for that matter, which has been addressed by oral semaglutide. Now, semaglutide, if you see the difference between semaglutide and liraglutide, which is the injectable form, is in this position number 8, where there is an alanine to alpha amino isobutyric acid. It protects against DPP-4 degradation. And this change is probably the only difference between liraglutide. Now, there is also a spacer attached to lysine 26, this 26 position. And in the arginine position, 34 position, there's the amino acid substitution. So there is a C18 fatty acid spacer attached to 26 in the 26 position of the GLP-1. And in the position 8, there is a change, and in 34. So 8, 26, and 34 are 3 numbers which we need to remember. Now, there is another unique feature of this oral semaglutide, which is it has been co-formulated with something called an SNAC. SNAC stands, you can read here, sodium N8 2-dihydroxybenzoyl aminocaprylate. Therefore, semaglutide has been attached to this SNAC, and this SNAC actually promotes the good absorption. It's an absorption enhancer, as you can see in this slide. So some oral semaglutide is combined with SNAC which is the real magic, how the peptides are working in the stomach. Therefore, we have the first in class, which is the oral GLP-1 receptor agonist, or we have the oral semaglutide, which is a new oral route of administration, the GLP-1 receptor agonist. And the problems I told you, the bioavailability is lower. There's a variability in absorption, which is mitigated by adding this SNAC. Now, the oral semaglutide gets absorbed from the stomach very close to the tablet, where the tablet is present. So it doesn't get absorbed from the entire stomach epithelium, gastric epithelium. It gets absorbed mainly from the SNAC. Makes sure that this oral semaglutide is absorbed locally from where the tablet is present in the gastric epithelium. So the absorption doesn't happen all over the gastric epithelium. It happens exactly at the place where the tablet is present. Now, do you have data to show that the oral semaglutide is effective? Yeah, so that's what I was talking to you about, the pioneer studies, the peptide innovation in early diabetes treatment. Pioneer stands for this abbreviation for this particular term. So you have a lot of trials, phase 2 trial, phase 3A trials, plenty of data, and 9,000 patients enrolled in this oral semaglutide. Before that, the injectable semaglutide was there. Now, the pioneer studies had a lot of subclasses. The Pioneer 1 was comparison of this oral semaglutide with placebo. Pioneer 2 was comparison with SGLT2 inhibitor. Pioneer 3, all of them are published. Pioneer 3 was comparing it with DPP4 inhibitor. Pioneer 4 was comparison with placebo. Pioneer 7 was a flexible dose with DPP4. Pioneer 8, interestingly, was a combination with insulin, add-on to insulin. There were some Indian patients. And Pioneer 5 was in patients with kidney disease. And Pioneer 6 is a CVOT trial. And importantly, patients, a very specific cardiac specific trial is going on, which is called the SOUL, Superiority SVOT trial, which is going on with about 788 Indian patients. Now, if you see the A1C, I'm going to talk to you first about A1C reduction. Across all the pioneer studies, you can see the durational studies which are mentioned here. And you can see the baseline HbA1c which is mentioned here. Now, across all the pioneer studies, you can see semaglutide, oral semaglutide comes in 3 doses, 3, 7, and 14 milligrams. And the comparison with placebo, comparison with empagliflozin, comparison with sitagliptin, comparison with liraglutide in patients with CKD, in the Flex Pioneer 7 study. Across all these studies, you can see there was a significant reduction in the A1C, and there was a dose-dependent increase in the reduction of HbA1c. Now, this is the 14 milligram dosage comparison compared to all the other agents which are shown in Pioneer, which I told you before. You can see that if you take a 2% reduction in HbA1c, the best response was got from 14 milligrams of semaglutide, whereas with EMPA, with sitagliptin, with liraglutide, you almost got 2% reduction. So you can see that the reduction of 2% A1C is excellent with this 14 milligrams oral semaglutide. Now, what about weight? So the two cardinal features of oral semaglutide is HbA1c and the body weight, about which we have the data from Pioneer. So you can see the baseline weight, which is mentioned here, and this is the duration of each study. You can see that the weight reduction was, again, maximal for people who were on the oral semaglutide compared to empagliflozin. You can see the difference compared to sitagliptin, compared to liraglutide, and even patients with CKD. And again, you can see the drop in body weight was linearly increasing as the dosage of oral semaglutide increased from 3 to 7 to 14. If you combine both parameters, that is a HbA1c reduction of more than 1% and a body weight loss of 5%, if you combine both the parameters, once again you can see that the oral semaglutide 14 milligrams compared to MPAR 25, liraglutide 1.8, and sitagliptin 100 or placebo, you can see that if you combine both these parameters, again, the oral semaglutide stands out as something which is beneficial and something which is superior to empagliflozin, liraglutide, and sitagliptin. Now, these are data from the Pioneer, and 6 looked at specifically the CVOT, and about 85% of Pioneer 6 patients had established CV disease, 85%. Only 15% had higher cardiovascular risk. And you can see that the HbA1c and body weight reduced significantly, and there was a primary outcome was also established. So that doesn't mean it's got data compared to SGLT2 on heart failure or CKD. Those studies are just coming in another 1 year. You have the FLOW study looking at the kidney, and we have the SOUL study, which is looking at the cardiovascular benefits. But in the Pioneer, you can see, and even in the LEADER study where liraglutide was used, it was shown that there was a benefit on the heart. But the benefit on the heart, there's no harm from using the drug on the heart. Whether there's benefit compared to SGLT2, only time will tell. And in the last part of my talk, in the last 2 minutes, I'll tell you how to take the drug. You should get up in the early morning, because you should wake up early morning, and take this tablet first thing you get up in the morning with 120 ml. They have shown that if you take higher amount of water, the tablet erosion is much more. If you take 50 ml, it is less, but people generally take 1 tumbler of water. So you can take about 100 and 120 ml of water, and there is no hot liquids allowed. So as soon as you get up, you have to first take the tablet and then wait for 30 minutes before having your coffee or tea or whatever, or taking any other medication. So if you're taking some thyroid tablet, you have to wait for half an hour after taking oral semaglutide. And you start with 3 milligrams in the first month, and then you move on to 7 milligrams. And this is pretty much what we do with liraglutide. We start with 0.6, build it up to 1.2, and then 1.8. So pretty much the same. And one point I said, it's got a long half-life because of its properties, of which I showed you in the GLP-1 chain, attachment to position number 34. It's got a long half-life of 1 week. So you can, even if you skip the dose 1 day, it doesn't matter. You can take the next dose the next day. You can't take it after food, after lunch, and so on. You should take it early morning. So if you miss a dose, tell the patient not to worry. They can take it the next day. So this is my second last slide. If there are patients taking 1 or more oral anti-hyperglycemic agents, including metformin, and this is probably the best choice as an appropriate agent as a second-line drug, as an add-on to metformin. Patients for whom weight loss would be beneficial, you should definitely consider the oral semaglutide. Patients who have hypoglycemia with insulin, you saw one of the Pioneer studies, 7, add-on to insulin. The insulin doses came down with 7 milligrams and 14 milligrams, not in 3. So you can see that there's an overall low risk of hypoglycemia. And the hypoglycemia is similar to all the other agents, and including liraglutide. If supposing somebody is already taking an injectable GLP-1 receptor agonist and not reaching glycemic target, you can use it, or the patient wants a tablet, you can change it. High CVD risk, we still need more data, but it is definitely cardiac safe. That's been shown in Pioneer 9 and so on. In CKD, you can use it even up to eGFR of 30. There's no problems, and it's safe in older people. And this is probably my last slide. Patients at high risk of CV risk, high CV risk. Of course, we know that SGLT2 inhibitor is the treatment of choice if somebody has heart failure or CKD. But if there is atherosclerotic cardiovascular disease, ADA says you could choose a GLP-1 receptor agonist, especially if the EGFR is not okay. You can definitely choose the liraglutide or oral semaglutide. Patients with low CV risk, of course, there's no question. You can use it with all the benefits which I have told you just now. So in summary, I think the oral GLP-1 receptor agonist is a real invention, as the peptide invention in early diabetes treatment pioneer studies showed. It reduces A1C, body weight, pill burden. It can reduce the pill burden. Oral semaglutide is a scientific breakthrough because we never knew that peptides can be given orally until this molecule has come into the market. The global pioneer trials have clearly shown that oral semaglutide is effective in A1C reduction and weight reduction up to 5 kgs. And when compared to SGLT2 or DPP4, of course, if you remove heart failure and CKD, oral semaglutide might be quite effective compared to these agents, and also as an add-on to insulin therapy. And in patients with baseline A1C of more than 9, you can get a good HbA1c reduction of 2%. And cardiovascular safety, the trials like the SOUL trial is yet to come, but it's got cardiac safety. Cardiac benefit, we have to wait for the results. So I'd like to thank you for your attention. Once again, thank Dr. Kanungo and also my good friend Jayant Pandey for the introduction. Thank you.